What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
Good morning, everybody. Dr. Zach Baker of Rehab to Perform and R2P Academy. And this morning, we are doing another one of our R2P Sports Residency Research Article Reviews. Today, we have with us Dr. Abbey Hammann, one of our two sports residents. The theme of the month is the hip. And Abby grabbed an article for us that I'm actually glad she got this one because I have a couple people that fit into this criteria, and I am going to be taking them through some of the processes that this article tries to spell out for us. And when I was trying to get some data for myself, I was having a hard time coming up with stuff. So this article kind of solidifies some of the struggles that I personally am having. And I think that the entire field and profession is kind of in the thick of it right now. And we need to figure out how do we move forward with a little bit more standardized way of doing things with this patient population. What are the benchmarks and the criteria that we're looking for? And how can we be consistent with this, not only from clinician to clinician within an individual PT facility, but across the whole profession? And I think as we dive into this article, a lot of it is going to sound like common sense, but we need to standardize that common sense. So, Abby, welcome on. And do you mind just telling the listeners what was the article that you chose?
So I decided to do an article based on return to sport, kind of criteria-based testing for that return to sport for individuals or athletes post-op for hip arthroscopy, primarily for impingement or FAI. Big thing with this article is that they were upfront and disclosed like, hey, we have not tested anything yet. This is more or less, we're just forming kind of our criteria and testing protocol. So they did a big analysis of a bunch of literature and then kind of came down to narrowing it down to about like 5 criterias. And each of those criteria is going to have some subscales that they're going to look into as well.
Awesome. And just to clarify, so this article is a clinical commentary. And the title of the article is a criteria-based testing protocol for return to sport post-op hip arthroscopy for impingement. And as we go through some of the background and kind of the reasons for why we have this is hip impingement and FAI. It's a very common cause of hip pain. And it's one that we're starting to find a little bit more prevalent in the clinic. And I don't know if it's always been around and we just have a better job of diagnosing it now and identifying it. Or maybe we've always been able to diagnose it and identify it. We've just never really had great surgical techniques or intervention techniques for it. So even if somebody had it, we never really did anything about it because there wasn't a great surgical approach, or it was a little bit unknown in regards to some of the outcomes. So, Abby, can you talk a little bit just about, some of the background of why this study was even brought on? We know that FAI is common, but can you get into the weeds a little bit with the numbers of really FAI and hip impingement?
Yeah, so generalized prevalence is inherently unclear for the condition, but a lot of articles that this article specifically pulled from were in regards to non-arthritic hip pain and FAI, and that was about 61.3% prevalence. Surgical intervention for return to sport has about only 57% of those individuals returning to play, and only 16.9% of people that undergo hip arthroscopy for FAI report optimal performance once they return back to sport. Additionally, the return to sport average is wildly variable. So that can range anywhere from 3 to 12 months. The return average they found was to be 7.4 months. Big thing for this article is the significant lack of consistency with the definition of return to sport and the rehabilitation programs that are in place. A lot of this is due to surgical intervention, surgeon preference, and just kind of our definition of return to sport holistically as a profession and what that means.
That's pretty wild. So they saw 51% surgical intervention for FAI saw statistically significant improvement in functional outcomes. That's a coin flip in regards to if you get surgery, half are going to have good outcomes, half aren't going to have any improvement in the functional status. It did say 84 to 87% did return to sport, but only 57% of them returned to their pre-injury level of competition. And like you mentioned, only 17% even reported being happy with their return, stating that only 17% even returned to what their self-prescribed optimal level was. We have wildly different time frames with returning, and I can attest to this because we are fortunate to have several physicians in our area who do hip labrum repairs, FAI, more complex hip surgeries, and it is extremely variable in regards to the recommendations that I hear from the different physicians in regards to how quickly you can progress range of motion, how quickly you can progress weight-bearing status, what they kind of value as some of your more influential factors that you need to be cautious with early on. And obviously some of that has to do with just situation by situation. And, if you have a certain amount of bony involvement with the surgery, if you have a concomitant FAI and hip labrum tear, that's going to complicate things a little bit. But there is not a huge amount of consistency in regards to surgical outcomes and then also just what we are seeing in the clinic with the progressions and what patients are reporting and demonstrating. So, Abby, can you talk a little bit in regards to, the whole purpose of this is to try to create some standardization in regards to the criteria that we care about and also how we're benchmarking some of that. Can you elaborate a little bit on what they deemed were the 5 essential criteria that we need to be aware of as PT professionals?
Yeah, so the 5 criterions are going to seem very basic and very in nature with physical therapists because it's going to be things that we're typically already looking at. Big thing with this clinical commentary is it's trying to put together a framework of, okay, these are the categories that we're looking at, but hey, these are the things that we need to look at more in depth and be a little bit more strict about before allowing some of these individuals to return to sport. So the 5 criterion categories that they were looking at were range of motion, strength, functional testing, psychological readiness, and time. They also framed up with this commentary is that, okay, these are the 5 categories, but also before, keep in mind healing time and all of that, because some of these things we won't look at until 8 weeks post-op, 12 weeks post-op. So you're going to have some checklist items, but don't think of it as a progression from range of motion, check, strength, check. Kind of think of them holistically as different bits and pieces, and they'll have levels that we're checking off as they progress through their post-op protocol.
Perfect. And I think that's an important thing to remember, not only with FAI, but all surgical procedures. There's a certain organizational hierarchy of how you move through rehab, and there are going to be some qualities that just naturally precede others. Or as you accomplish one quality, it allows you to work on the next a little bit more efficiently. But there's going to be a lot of overlap that happens as well. And you don't work just on range of motion in isolation. Then you get to some magical benchmark that allows you to begin introducing strengthening. All of it's relevant, and you can always have all of these different qualities as a part of your program. It's just how much are you emphasizing one or another may vary based on the phase of rehab that you're in. Now, let's kind of go through these one by one, and you were right. They do sound pretty common sense, like, hey, I just had hip surgery. I need to get range of motion back. That doesn't seem too groundbreaking, but unfortunately, I don't think we do a tremendous job just throughout the field of really if we are establishing range of motion and restoring it, are we actually confirming that? Are we measuring it? Do we have certain guidelines? Or are we just kind of eyeballing it or assuming that it's getting better? So for clinicians that are out there, we have an FAI surgery. We care about range of motion. Based on the clinical commentary, what are they saying we should test? And what is our criteria for saying, perfect, we can put a checkbox next to this. We are good to go with range of motion.
So with range of motion, you're going to look at kind of all the directions of the hip. So you'll have flexion, extension, abduction, adduction, ER, and IR. With that, the passing criteria that they've kind of formulated is that all hip ranges are going to be within 5 degrees of the contralateral side, and they have to be pain-free. If they're not pain-free, that's a big problem, and that's one of the things that they had talked about earlier in the article, is that a decent amount of individuals were complaining of inability to return to sport because they didn't have any of the deficits as far as range of motion and strength, but they were continuing to have pain with things.
And that is important to note because I've had individuals in the past who they underwent FAI surgery because they were having pain with your typical impingement-related positions, flexion, adduction, internal rotation, noticing it a lot with pivoting, twisting, multi-directional movements, or that deep squatting position. And that was, with those individuals, they often restored range of motion very, very quickly. And the surgery, it makes sense. Oftentimes they're doing some sort of debridement or resurfacing, or they're kind of reshaping the anatomy of the bone. So in theory, there shouldn't be that mechanical blockage or as much of one anymore, noting if there's some sort of cam or pincer lesion that's influencing that. But oftentimes they still had pain. And this is an early conversation that I like to have with the patient and have it guided by the orthopedic surgeon who was in there and actually did the surgery as to what are our expectations with this? Is the pain that we're having early on just normal post-operative discomfort, either because of the location of where the arthroscopy was or because of general inflammation or just healing that's taking place? Or is this something that is abnormal and we need to get the ortho's eyes on this again and figure out how we can structure rehab moving forward? So I think the range of motion with regards to just comparing to contralateral limb, pre-injury status, or just what a textbook says they should have, that's all pretty common sense. But I think getting on top of that pain conversation, it allows you to move forward a little bit more confidently as a clinician, and it removes or reduces a lot of the unknowns of a patient in regards to what's okay to push through, what's normal, and what's abnormal, and maybe I'm doing a little bit too much, either from a volume or from a range standpoint. So range of motion I feel comfortable with. Let's talk a little bit about strength testing. And strength testing is a very large umbrella of a topic to talk about. And there's a lot of different ways that you can go with this. And I would encourage everybody to use clinical judgment in regards to what are just universal things that we care about and what are some additional strength measures you may use based on your individual's sport or desired athletic activity. But in this article, what did they talk about from a strength testing standpoint?
So there were 4 categories of strength testing that they included. One was handheld dynamometry. The other was bunkie tests. The third was a single leg bridge test. And the last is isokinetic testing. They kind of framed it up as, hey, these are our 4 tests that we need to check off. But keep in mind that you'll always start with just a subjective manual muscle test. If they're able to kind of achieve that 5 out of 5, that's when we'll go through a little bit more of the effort and bring out the handheld dynamometry and get more numbers on that. But initially post-op, first couple weeks, when you're able to start testing strength, just start with manual muscle testing. With this, one of the biggest things I learned was bunkie tests. It might just be because I'm a new grad, but that's not something that I've heard of before, and that's kind of assessing core stability and then just general stability of lateral, medial, and posterior chains.
Awesome. And with the isolated testing, so you talked about handheld dynamometry, using manual muscle testing as kind of a preceding test to that. And I think that's a good example to utilize where earlier we talked about these 5 different categories. There's going to be phases and there's going to be progressions to them. And you may not go through, if you're in a time crunch condition in the clinic and you're early on post-op, it may not be the most appropriate and effective utilization of time to go through the all the different handheld dynamometry measurements for somebody that ultimately it's not going to make a huge difference in what you're going to do the next week with their plan of care, and it's not going to release them from PT. And also, you may not want to do a max effort handheld dynamometry test with somebody when you don't even know how well they're going to tolerate submaximal effort. So I think progression towards handheld dynamometry, just watching them go through exercises. How well are they going through their active range of motion activities in these isolated planes? How well can they accommodate and handle your own manual resistance? And then that gives you a really good idea of, hey, this is somebody that I think I can get a meaningful measurement with some handheld dynamometry or inline dynamometry. The bunkie testing protocol, that's another great one to use. Were there any other ones that they had mentioned, either posterior chain or something that's a little bit less isometric and more isokinetic?
So the single leg bridge test was going to be for reps, and you're comparing limb symmetry. So are they getting an equal amount on each side? They're also looking at things like, does the individual show good glute activation? Do they maintain a neutral pelvis throughout the movement? And do they achieve full hip extension at about 0 degrees? So not past that, but 0 degrees of hip extension. Are they able to get to that neutral point?
Awesome. And then I think the important part to think about with that, standardize a single leg bridge, pretty easy to administer, but we need to standardize testing procedure. So in here, it references a 60 centimeter high box, 20 degrees of knee flexion, achieving a neutral hip or 0 degrees of hip extension. And then with that, qualitatively, it looks like the way that a bridge should look. You do not need to start with that. You don't need a 60 centimeter high box right from day one. You can have them do bilateral bridges, demonstrate competency with that, then progress to single leg, then progress to single leg from an elevated height. So keep in mind, you can work up to these tests as you work through the protocol as well. And then finally, isokinetic testing. This is kind of the gold standard if you're just looking at force output, torque measurements, and really a lot of the different raw data that you can capture from the hip joint at various ranges of motion with various metrics with regards to force output. The tough part is we don't all have access to that. So I do like how that is just one of the several different pieces that you can utilize. And with the different criteria they mentioned here, everybody is more than capable of doing at least 2 of those criteria in the clinic. Now, functional testing. Functional is kind of air quoting right now, kind of a big buzzword. But when I hear functional testing, I just think of it's some sort of integrated, multi-joint, multi-planar motion, probably weight-bearing. It's something other than just a non-weight-bearing isolated test. So what were some of the functional tests that they mentioned?
So there were 3 tests that they mentioned. One of them was a step-down test. The second was a Y balance test. And the last one was hop testing for distance. The step-down test, you're looking for limb symmetry side to side. Are they able to achieve the same number of reps? But similar to the single-leg bridge test, up, above, and strength. The step-down test, you're going to look for a couple different things. What is their trunk movement like? Are they having any of that? Are they remaining stable? What is their pelvis posture? Posture of the hip joint, posture of the knee, and the depth of the squat they're able to achieve on each side. So with that, you're looking at not only at repetition, but you're also looking at those 5 criteria, and are 4 out of 5 of those negative for deviation? If so, that constitutes as a passing score. If they have less than 4 than 5, then they're not passing that test. And if they don't have limb symmetry, obviously they're not passing that test as well. But I think that was super helpful for me to see is, hey, we're not only looking at repetition. Do they have that side to side? How does it look qualitatively side to side as well?
Awesome. And then outside of that, we also have our Y balance test. Again, looking for limb symmetry. Also qualitatively, you can assess. We have hop testing, and you can look at this either with your traditional horizontal hop testing profile, or if you have force plates or some way to capture a vertical hopping profile. Some good data there in regards to either limb symmetry or normative measurements. Now, moving along from functional testing into self-reported function and physiological readiness, or kind of their psychological state in regards to how they personally feel. Did they reference some different outcomes measures that we can utilize as clinicians for our patients?
Yeah, so the authors of this commentary were kind of disappointed in the outcome measures that are available for individuals that are returning to sport. So they listed 3 that they would use. The HIP RSI to assess psychological readiness to return to sport. The IHOT 12, just for ADLs and stuff like that. Can this individual get through normal day-to-day stuff and then some sports subscale stuff without any difficulty or any disability? And then the last was the HOS sports subscale, and that was the part that they used for the return to sport phasing. So those 3 kind of encompass the 3 things that we're looking at. How are they doing in their day-to-day life? How are they doing in regards to participation in their sport? And then how are they doing from that mental standpoint and psychological readiness to return to sport? Because as we know, psychological readiness is a big predictor in injury prevention and decreasing injury or decreasing the effects of re-injury.
Good. And then the final criteria, the component of time. And obviously, each individual surgery and what was actually done, the amount of bony involvement, if there is any soft tissue repair or involvement is going to modify time frames. But what did they touch on for some considerations with regards to the time factor?
So in the background, we kind of talked about how return to sport timeline is super variable. So you can be from 3 to 12 months with the average of 7 months. The time component within this commentary was the athlete has to be between 5 and 6 months post-op before we're even considering returning them to sport. And with that, they have to pass all of the criteria we just discussed, and each failed testing component needs to be retested every week to 2 weeks until they pass. The only one that you're not retesting every week or 2 weeks is going to be the isokinetic testing, which you'll wait about a month and a half before retesting that again.
And that makes sense. The isokinetic testing, if it's true strength power output that you're looking at, that's going to take time to develop. And testing it on a week-by-week basis, you may not get meaningful data. It's also probably just logistically not feasible to even consider that as well. The 5 to 6 month mark makes sense. I think of FAI rehab as the first 3 months. You break down into 6 weeks, and then week 7 through 12. The first 6 weeks, restoring daily ambulatory activities, getting symptoms under control, starting to progress range of motion, and just general independence. Then weeks 7 through 12, you're trying to clean up as many impairments as possible. So with regards to range of motion, strength, and movement quality. So the first 3 months is, in my head, kind of very rehab heavy, meaning it looks like a lot of the stuff you learn in PT school. The next 3 months, months 4 through 6, that is reconditioning, and that is getting them back into shape. It's taking a lot of your rehab activities, putting some sport-specific context to them with regards to movements, with regards to different stimuli, but then also intensity and volume of tasks as well. And then anything beyond 6 months, a lot of that has to do with either their individual progression or what are they returning to and how complex of a sport is it with regards to the demands or the competition level that they're returning at as well. Abby, any kind of last thoughts or takeaways from this that you want to share?
Big things that I would point out is the article is from 2023. So it's a newer article, and they were still reporting that there's no validated return to sport testing, which is important to know that this is something for us to keep an eye on. The authors also plan to validate this protocol with an official trial. So that's something for clinicians to keep an eye out for if they do go ahead with the trial. What does that mean? What are the results? And how does this protocol actually go into play? And is it something that can be usable in the future for us as clinicians as kind of like a testing battery for return to sport?
Awesome. So big takeaways from this. We don't have conclusive information to utilize, but we have common sense and we have ways that we can standardize things. And I think the biggest thing that we need to do as clinicians is, if we know what we value from an outcome standpoint, which they broke down into their 5 essential criteria, then we just need to make sure that we're doing a good job of measuring the things that we value. And the things that are measuring out well, good, relay that on to the patient. The things that are not measuring out well, make sure we're modifying plan of care appropriately and make sure that we are retesting them again. And ideally, you're putting your athletes in a position to not only perform well, but be at a lower risk profile for when they return to sport. So, Abby, as always, thanks for doing the dirty work for us and getting this research article, and we look forward to having you on next month.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.